Okay, good afternoon, everyone, and welcome to the MCRH Infectious Disease Echo. My name is Victoria, and I have the privilege of moderating today's session. The topic for today's session is endocarditis for primary care providers. Just a couple announcements. For a more collegial environment, we'll use first names only to be conscious of confidential protected health information. Raise your hand if you have a desire to speak, and to keep your microphone on mute until you are ready to speak. And then also before you speak, please say your name so we know who is talking. Our presentation will be available to everyone following today. I will send out a copy of the recording and then also a copy of the slides. The value of the echo is in case studies, so please volunteer a case. The case form can be found on the MCRH website. And then also just as a reminder, cases can be something as simple as just submitting a question. It doesn't have to be super complicated. We will go at this time to just introduce ourselves. So we'll go around and we'll state whoever everybody is on today's echo. We'll go down the list and I'll go first. My name is Victoria and I am with Michigan Center for Rural Health. Next I have on my list is Peter.
I'm Peter, I'm from Michigan State University and I'm going to present the topic today.
And then next I have Allison.
Hello, my name is Allison Lukenbill. I'm calling in from the Michigan Department of Health and Human Services, and I'm one of the disease intervention specialists for hepatitis C.
Thank you. Next, I have Courtney.
Hey, Courtney Wicks, also disease intervention specialist with the State Health Department.
Thank you. Next, I have Emily.
Good afternoon, everyone. My name is Emily. I'm also a Hep C disease intervention specialist with the Michigan Department of Health and Human Services.
Thank you. Welcome. Next, I have Heidi.
Hello, I'm also a DIS for MDHHS. I work in Hep C.
Thank you. Welcome. Next, I have Lindsay.
Hi, my name is Lindsay. I'm an RN substance use care manager with Alcona Health Center.
Thank you. Welcome. Next, I have Heidi. Did I say Heidi already?
Yep.
Okay, sorry.
You're good.
Next, I have Sarah.
Hi, yes, my name is Sarah, and I'm also a disease intervention specialist for the State Health Department and work with hepatitis C primarily.
Thank you, everybody, and welcome to today's program. Just wanted to recap from our session last month. Are there any updates, questions, or clarifications arising? Our topic last time was congenital infections. Our speaker was Melissa Rosenberg. She isn't here today, but if we had any questions, I'm sure Dr. Gulick Peter could either answer them or we could get any clarification from Melissa. Okay. And then also something to keep in mind, please consider one thing that you have learned from this session to put into the chat box at the end of our sessions. At this time, I will introduce Peter and then I will share my screen and we can begin our presentation. Just a little bit of CME information here. Everybody will be able to get CME for the session. I will also include this in the follow-up email. Where is my slideshow? Okay.
All right, so we're going to get started and thanks for everybody showing up today. And what I'm going to talk about is endocarditis, and that was a request that was made for this topic, but I'm going to make it appropriate for the areas of that we've been concentrating on through this whole teleweb, and that's been rural areas and rural problems and people living, with, IV drug use issues. And so to start with, I have no disclosures. Next slide. And so these are the objectives. We're going to discuss the epidemiology, general microbiology, pathophysiology of endocarditis, but we're going to look at it specifically in people with IV drug abuse problems. And we're going to discuss the clinical presentation and then how to work somebody up for it, and then discuss some prevention aspects about how to prevent endocarditis, especially with PWIDs, and then finally go into a case as well. Next slide. Next slide, please. Good. So to start with the epidemiology, this is just general epidemiology. So when you look at endocarditis, and that just simply means infection of the heart valves, it used to be a little bit more rare in the early days, maybe 5 to 7 cases per 100,000. But recently, and since 2011 till about 2018, the incidence has increased. And there's several reasons why. One is because there's more healthcare associated endocarditis, meaning that individuals that have, infusion ports placed for chemotherapy, for other issues, or IV lines that are in, or intracardiac devices, pacemakers, things like that. They all have devices that have catheters into the blood vessels. And so if they happen to get infected, that blood vessel, that catheter could get infected, and then it leads to bacteremias occurring, which can then eventually infect a valve. So that's one of the reasons. Next slide. The other reason is because we're seeing it more in individuals that are, injecting drugs. And as we've gone over before about risk factors for hepatitis C, and especially up in northern Michigan, where we have a lot of, injection drug abuse problems because of the opioid epidemic. We saw complications with Hep C as well as HIV. One of the other complications that occur from IV drug use is skin-related infections from the, injecting drugs through the, through veins and things like that. That can lead toward younger age now that have been using opioid abuse. And now are on IV drugs are at high risk, not only for Hep C, not only for HIV or other issues, but also for skin-related infections, including endocarditis. Next slide. So how does it occur? And one of the things that occurs uniquely in patients with IV drug use that get endocarditis is a lot of the drugs that are injected are mixed with other compounds. And so some of these can damage the valve. So a person with endocarditis, usually, for those of you that have been or have heard a lecture or maybe read about it, you always hear about a predisposed valve, a rheumatic fever valve, or a valve, prosthetic valve that might have already had an injury to it. Well, with PWIDs, the valve can be a normal valve, but because of the injected substances, they can damage the intima of the valve, and that can cause issues to occur, which I'll get more detail in. That can be a predisposed valve then toward bacterial colonization and infection, which results in endocarditis. And the common organisms, probably the most common, is Staph aureus. And then there's other strep organisms that are usually like Strep viridans. Those are usually organisms that are in the mouth. So those are the two most common organisms that we see, especially with people with, with IV drug use endocarditis. Next slide. And so to kind of go, kind of summarize things, who is at risk for infective endocarditis? Well, individuals that have predisposed problems like, acquired valve disease, rheumatic heart disease, prolapse valve, any kind of a heart murmur, from, bicuspid aortic valve are at risk. Anybody that has a prosthetic heart valve is at risk, or that has had a prior episode of bacterial endocarditis because their valve is already damaged. But also healthcare related. Like I said before, almost a third of cases of endocarditis are from this condition, where you have infusion ports. And there's so many individuals now that are getting chemotherapy or getting other IV products, and they have to have an infusion port put in. They are at high risk for endocarditis, as well as those that have pacemakers and things. And then finally, the IV drug users. That's the other area that we're seeing more cases of endocarditis, the younger age group. So it's I know one of the first slides I said it was mainly seen in older individuals. Well, there's another spike, and that spike is in young individuals that are opioid abusers and IV drug users. Next slide. So this is a nice description of how endocarditis occurs. So you can see there that there's a normal valve. It's a nice smooth structure there. And then there's some damage that occurs to it. And we've talked about what can cause damage, but let's look at the IV drug users. You know, the drugs they inject, many times it's mixed with other compounds, and those compounds can cause damage to the heart valve. So there's damage to the intima. Well, what happens when there's damage is that the body reacts to that to try to heal that damaged area, and it activates platelets and fibrin. And so platelets and fibrin go to those damaged areas, and it's almost like glue on there. It's like a real sticky, substance on those damaged areas. And they actually, over time, will form like a little mass on there. Like you'll see, it says non-bacterial thrombotic endocarditis. The damaged valve has a little button there, a little growth there, so to speak, of all these platelets that are forming there. So now let's look at bacteremias. And people get bacteremias from brushing their teeth. So if they have bad dentition, they can scrub their teeth real bad, and they can shower bacteria. And the body normally reacts and it clears those bacteria rather quickly, and there's no damage done. But if there's a damaged area in the blood, where the blood goes, like a valve, those bacteria can stick to that sticky surface. And that's where you start getting bacterial growth on those sticky areas there. And, looking at an IV drug user, when he's injecting, drugs through a vein, he doesn't always use, or she doesn't always use, sterile equipment in that. And so that can lead toward bacterial showering. And that's where you get Staph aureus being a common bug, because many people are colonized with staph. And when you put a needle into an area that has staph, and then it goes right into a blood vessel, the staph carries itself. And so now you have bacteria that are growing on this platelet island, so to speak. And now you see what's called infective endocarditis. And that's where the valve is severely damaged and where you get the clinical consequences of that. Next slide. So what are the clinical manifestations? And we're going to talk in great detail about these so that you understand what clinical complications occur as a result, or what are the clinical presentations that occur in complications as a result of endocarditis. So first of all, there's just systemic symptoms that occur. There's an infection, so usually people get a fever, they'll get night sweats, they get fatigue, achiness, myalgias, arthralgias, nothing really specific other than a fever indicating some kind of an infective process. Then as the valve gets damaged, and you see that, you remember that large growth on the valve, that's a very unstable structure. So the valve doesn't open and close properly. And so the next most common symptom is a new or changing heart murmur. And then obviously the bacteria can form abscesses, or it can go right into the heart itself and cause damage to the conduction system. So patients can get arrhythmias from this as well, and then a mild pericarditis. The other thing that can occur is these bacteria shower the body. So there's constant bacteria in the bloodstream, and they can actually weaken the blood vessels in certain areas. For instance, the carotid arteries, the cerebral arteries, things like that, where it forms a weakness in the vessel wall, and it can cause an aneurysm that can explode unexpectedly and spontaneously. And then finally, there's what's called embolic. When there's little fragments of that vegetation that break off, they're like little fragments of platelet and bacteria, and they can lodge in blood vessels and cause emboli to occur. We'll talk more detail about that. Next slide. So what are the clinical what do you see most commonly in people that present with a damaged heart valve or endocarditis? Number one is a fever, because the majority of cases are all bacterial. Staph being the most common, strep also occurring, and then there's other bacteria that can do it as well. So fevers are very common. The other thing is, because it's an obvious damage to the heart valve, like I showed you in that picture, the valves don't close normally as efficiently, and a heart murmur forms. So a patient may have a pre-existing heart murmur from, say, a rheumatic heart disease or from a prolapsed mitral valve, And so person may have, but then all of a sudden it changes, it gets worse. Or a patient never had a heart murmur, and now all of a sudden they develop a new heart murmur. That's because the valve has been damaged. And most commonly with endocarditis, it's visually that abnormal platelet bacterial growth on the valve where it can't close. And so it could be a new murmur or a changing murmur. That's the next most common presentation. The third most common presentation is where the valve shoots off these little fragments of this platelet bacterial growth and form emboli in different areas of the body. So you see a young man coming in or a young woman coming into the ER that 18 years old with a stroke. And, strokes are usually in older people from, vessels that have been damaged from cholesterol and triglycerides and coronary, from disease that's been going on for decades, not a young person with a, normal vessel. So what could cause a stroke in somebody that young? Probably embolic. And if they have a history of IV drug use or something, more likely than not an endocarditis where the fragment broke off and then lodged in one of the carotid arteries and caused a major stroke to occur. And then some of the other skin manifestations that I'll show you examples of are a result of either these small emboli or immune-related complications. Next slide. So let's go into more detail and talk about the clinical manifestations. Let's talk about the infective processes on the valve. Let's talk about embolization. Metastatic infection means that the infection is spread to other organs. So, if it goes, the blood goes through all organs of the body. So you could you could get an infection of the kidney, infection of the spleen, infection, of other organs based on the fact that these bacteria can lodge in those organs. And that's what's meant by metastatic infection. And then immunopathogenic mechanisms means that the body reacts with white cells, with antibodies, and the antibodies bind to the foreign process and form these little immune complexes that can also cause complications. Next slide. So here's the, now we're looking specifically at what are the complications that occur when the valve gets damaged. And so, as I mentioned earlier, you visualize that abnormal valve. And so you're going to get a heart murmur, either a new heart murmur, or if there's a pre-existing murmur, a change, usually a worsening of the heart murmur. You're going to get fevers. You're going to get fatigue, arthralgias, myalgias, and even weight loss. And this occurs over sometimes weeks. It doesn't occur like instantaneous, like you get the bacteria in the bloodstream and then the next hour, next 5 hours, next 10 hours, you're going to get symptoms. Sometimes this drags on for a week, sometimes a little longer. Because the heart doesn't have the proper valves to keep the blood in proper locations, heart failure can occur. And then you get these non-specific complaints. Patients coming in, they have a fever, they're achy all over, their back hurts, and things like that. So those are the main complications when it affects the heart. Next slide. Now, if you can visualize that those little structures, it looks like little cords, though on the left side, when you're looking at this on the left side, that's a normal valve over there. You can see those cords nicely going on the valve. Look over on the right side and you'll see that big, ugly looking growth on the valve there. And you don't even see the cords anymore. That's a vegetation from somebody that had bacterial endocarditis. That's the vegetation. And that you can see how friable it looks and how it can just, with the blood constantly hitting it, pieces can fall off of it into the bloodstream and form these emboli. So that's the process that I'm talking about. That's a bacterial endocarditis. Next slide. So what about the embolization? What does that cause? Well, it can embolize into the lungs because the heart, obviously forces blood in the lungs, and people can get these multiple little nodules in the lung from all these emboli and develop pneumonia. I mentioned the stroke, especially when you see it in a young person that should never get a stroke because they don't have underlying coronary artery disease or underlying vascular disease from years and years of high cholesterol and triglycerides and hypertension and diabetes. It can lodge in the spleen, it can lodge in the liver, it can lodge in the kidneys and cause complications. And then a young person comes in and they have a heart attack. 17 years old and a heart attack. What would do that? Well, if one of those little emboli lodged in the coronary arteries, it would cause infarction to occur. And then if the vessels, if the vegetations are large, they can lodge in one of the major arteries, like in the leg, and it can cause a complete ischemia of a lower extremity where they can get extreme ischemia. And then some of the peripheral manifestations, which I'll show you in just a second. Next slide. So these are some of the peripherals. So you have a person, unexplained fever, myalgias, arthralgias, they have a new or changing heart murmur, and now you do a physical exam on them, and you notice that little red spot in the lower eyelid there, that's a little hemorrhage there. And that's from a vasculitic process that occurred as a result of the endocarditis. A little fragment of that material came in there, lodged in a small vessel, and caused that little blood vessel to burst and form that lesion. Next slide. And that's on the fingertips. So let's say you're doing an exam and you notice that all of a sudden this patient says, geez, I didn't notice all those little funny little nodules that you see there on my fingertips. That just came on over the last day. I never saw those before. And some of them can be a little bit painful and tender. That's called an Osler's node. And the same pathogenesis. You either get immune complexes that go in the vessel and then the vessel bursts, or the actual emboli goes in there and lodges the blood vessel, blocks it, and the vessel bursts and forms those painful nodules on the fingertips or toes as well. Next slide. And this shows you one on the toe, that little red area there, same thing. So if you have somebody that's got these symptoms and all of a sudden you notice these different lesions forming on the extremities, that is very, very solid evidence that that patient has an endovascular lesion, most likely an endocarditis, and that's the cause of those things. And if they're big clots, those are real tiny ones, but if they're big, they'll lodge in major blood vessels and cause a stroke or cause a hemorrhage or cause a, you know, I had a lady one time in the hospital that I was treating for endocarditis, and she woke up one morning and had a severe headache. And before we could start working her up, she became comatose, and we did an MRI of her brain, and she had a diffuse brain hemorrhage. And what had happened was the endocarditis lodged in one of the brain arteries, the middle cerebral artery, and caused a weakening of the blood vessel wall, and it just burst and she died from a hemorrhage. So her endocarditis was getting under control, but unfortunately she died from that. Next slide. And these are maybe hard to see, and I apologize, but there's little splinters on the nail beds there. You'll see little lines going through there. And some of these can occur from trauma, like you see people that like work on jackhammers where they're constantly getting vibration in their fingertips, and that can cause vessel damage and can cause similar type things. But this is from somebody with endocarditis where the vessel is just ruptured and you see these little splinter hemorrhages on the fingertips. Next slide. And the same thing here. This is a little bit more visual now. You can see the little red area there on the middle finger there, and then on the finger to your right, you can see two small little lines there. Those are what's called splinter hemorrhages, all as a result of these little emboli going to distal areas of the body. Next slide. And this finally is a slide of an eye, a retina. And you can see here, the vessels are these nice, you know, those nice long, you can see the blood vessels there, but you see all those little blotches of red all over. Those are where the vessels ruptured and formed these hemorrhagic areas. And this can lead toward obvious visual abnormalities and sometimes even blindness for that matter. But these all are related to the immune complexes and or emboli lodging in these blood vessels, causing these hemorrhages to occur. Next slide. So what other manifestations can occur in endocarditis? And we talked about emboli, we've talked about the damaged heart valve. Well, these are other ones where it can cause weakening of the arteries, and it can cause spontaneous rupture, like I just showed you the example of. Or if they go into organs, you can see multiple abscesses, say in the spleen, the liver, the kidneys, et cetera, and can cause multiple complications there as well. Next slide. And so when you look at these weakening in the vessels, you know, we already talked about what can happen if somebody happens to get that in the middle cerebral artery there, and that was a patient I just presented to you, and they can occur in other areas of the body. It can occur in the vascular supply to say the stomach or the intestines, where you get the vessels that give blood supply there. If they get blocked all of a sudden, you get this severe colicky pain where patients develop ischemia in the bowel or in the stomach, and it can cause severe abdominal pain and usually bloody diarrhea. And the same thing with the liver. If it happens to hit the artery going to the liver, you can develop acute ischemia of the liver with a severe ischemic complications with the liver, with massive enzyme elevation and even liver failure for that matter. And then if it happens to go to one of the extremities, like the lower legs, et cetera, then you can get severe ischemia of the leg. I mean, you can get acute ischemia with pain, and if it's allowed to go long enough, even gangrene and things like that. So these are some of the complications when the infection lodges in the large blood vessels and causes weakening of the vessel itself, and they spontaneously either occlude themselves or rupture. Next slide. So now you've got patients presenting, you've got patients with physical findings. How do you diagnose it? Well, obviously, since it's a blood-related complication, you want to get blood cultures. And usually, you know, patients when they have, say, a pneumonia or say they have a kidney infection, if it's severe enough, sometimes the bacteria can go in the blood vessel, but it's like a one-time thing. It goes in the blood vessel and then the body clears it right away. So it's only a single episode. With endocarditis, it's an endovascular complication. The infection is in the bloodstream, so to speak. So it's in the heart, actually, and there's constant blood going through it, constant. So you're going to get constant bacteremia. So usually you'll get one culture, 2, 3, 4, 5. All of them will show the bacteria in it because it's a constant bacteremia going on. And so that's one of the major ways of telling that it's an endovascular lesion, constant bacteremia. And then you're going to get the bacteria isolated. The most common one is Staph aureus, especially with our IV drug users. But there's a bunch of other bacteria you can see there. Strep viridans, strep, these are all organisms that can be either from the gastrointestinal tract, from the skin, or from the mouth. And so this is one of the major areas of making the diagnosis, a bacteremia that's constant. Next slide. Number 2 is, well, if they have a constant bacteremia, where's the origin? You know, if somebody had a catheter put into their vessel, that catheter could develop a vegetation and be the origin of it as well. So how do you implicate the heart? How do you implicate somebody to say they have endocarditis? Well, you do an imaging. And the imaging that we do is to try to identify that abnormal valve that you saw in those pictures before. So an echo is the most common way of doing it. And the 2 types are either a transthoracic, TTE, or a transesophageal, TEE. But basically, both those look at the heart and the valves in great detail, and they can pick up a vegetation very, very easily. And if there's a real problem with it, say you have a prosthetic valve that's already a little abnormal, you're trying to differentiate the valve abnormality from the endocarditis, you can do a little more fancy test like a PET scan in that. But for our discussion, the echocardiogram will pick up the majority of cases. So now you've got bacteria in the blood, you've got definite evidence of endocarditis based on the vegetation you've discussed or you've diagnosed on echo. Next slide, please. So this is where the diagnosis is all put together. So patients with a predisposing condition that would make you at high risk for endocarditis, either a predisposed valve or a prosthetic valve, or a person that's an IV drug user. That's a high risk as too. So that's why I'm concentrating on this condition for our purposes, you know, when we're talking about endocarditis, or when we're talking about conditions that occur in opioid abusers and IV drug users, because that's been the theme of a lot of these echo presentations this year. And so this is the theme today as well. So it's a predisposing condition They develop a fever. You find abnormalities on physical exam, be it a heart murmur, be it various vascular abnormalities like emboli or something in that category. The immune complexes can cause renal conditions like glomerulonephritis. They can cause those little lesions I showed you on the fingertips or on the toes, which are Osler's nodes or Janeway lesions. And then Ross spots are those hemorrhages in the eyes. And so you've got all the ingredients here to make the major diagnosis of endocarditis. And that's what's meant by major Duke criteria. That's the criteria that we use. Next slide. And so what are complications that can occur? And the complications are heart failure because the valves no longer work properly, conduction abnormalities where a person can all of a sudden, you look at the EKG and their heart, you listen to their heart and it's irregular or it's rapid rate or something, and the EKG shows definite. It's because the infection has burrowed itself into where the conduction system is in the heart and damaged it. And that's a serious problem where you need an immediate pacemaker put in order to save somebody's life. Or a myocardial infarction where the bacteria go right into the coronary arteries and plug them up, and so people get that. Embolization, we talked about. Neurologic manifestations from carotid artery complications, cerebral artery, aneurysms, things like that. So those are some of the major complications that we see in somebody with endocarditis. So how do we treat it? Well, number one is we treat it with antibiotics. And so we use the antibiotics usually intravenously, and we give it to them for a prolonged period of time, sometimes 4 weeks, sometimes 6 weeks, sometimes even 2 months, depending what the organism is. And so it's not just a simple week of antibiotics or 2 weeks, but it's a long course of antibiotics. Next slide. What about if the patient's worsening? You've got them on antibiotics, but their heart is getting worse. They're going into heart failure. It's because the valves aren't working anymore. Or you've got evidence that there's abscesses in the heart, that the conduction system's abnormal, that there's things going on there despite antibiotics, or repeated emboli. Some of those emboli are huge. And even with antibiotics, they don't get rid of the emboli. They don't all of a sudden melt away, but they're still there and they're still showering emboli all over. Those are the indications that you have to get a surgeon on board immediately. And even if you haven't had the infection treated completely, that surgeon has to go in there, take out the diseased valve that's got all those, massive growth on it, and even clear out part of the heart area there that might have an abscess and put a new valve in place there. So that's why you see the indications here for surgical indications where you have, repeated emboli, you have somebody that's going into heart failure. A prosthetic valve, unfortunately, because it's not a normal valve and it doesn't have the normal blood supply to it, many times will have to be replaced as well because the vegetation, even with good antibiotics, the antibiotics don't have blood supply to take them to the prosthetic valve, so they have to be replaced as well. So these are some of the indications where we not only have to do antibiotics, but we have to do surgical correction as well. Next slide. So what about prevention? And so, with the people who inject drugs, how do we do that? And so again, we talked about needle exchange programs. We talked about harm reduction, trying to keep those needles as sterile and as clean as possible, not only to prevent transmission of HIV and Hep C, but to prevent transmission of bacteria as well. And so that's one area that can be very, very important. So syringe exchange programs and cleaning, making sure they have clean paraphernalia as well. But even those may not completely eliminate the chances for endocarditis because, when you go into a vessel, sometimes the cleaning isn't proper, sometimes it isn't, and you can still drag bacteria in there, even with a clean needle and clean paraphernalia. So there's always a risk of endocarditis, unlike reducing the risk of Hep C and HIV by getting syringe exchange programs. Trying to eliminate the drug problem is the biggest role in prevention of endocarditis and PWIDs. So opioid abuse programs or opioid use disorder programs where they use buprenorphine, methadone, naltrexone to try to eliminate their IV drug use complications. That is probably the most important way to prevent endocarditis in the PWIDs. And then obviously that's also going to be effective in preventing HIV and hepatitis C as well. So again, probably the medical assisted programs where we get rid of the IV drug problems is probably the most important way of preventing endocarditis in PWIDs, followed by syringe needle exchange programs. Next slide. And so this just talks about, the comprehensive harm reduction services, that we have, and by, accessing sterile needles and equipment and that's going to reduce the incidence. But with endocarditis, it definitely won't eliminate it. And again, because of the fact that, a lot of times you can't eliminate even with stuff as clean as can be, the colonization of bacteria on your skin. And unfortunately, a lot of IV drug users, about 30%, well, 20 to 30% are colonized with Staph aureus on their skin. They have that bacteria on their skin already. So when they put the needle in there, they're dragging the Staph aureus right with the needle into the vessel there. And then obviously, using HIV pre-exposure prophylaxis and most important medications for opioid use disorders and that to get them off their IV needles and things. That's going to be the most effective way of preventing complications of endocarditis, especially in the PWID. Next slide. So what about the PWID that already has had endocarditis? They've either got a prosthetic valve or they've got a damaged heart valve from the endocarditis, either one or the other. So what do we do there besides getting them off the IV drugs, which is very, very important? Well, the other thing is, since they've got a predisposed damaged valve now, they're always going to be at risk for endocarditis, even if they don't use drugs anymore, because like I said before, brushing your teeth, different procedures can cause transient bacteremias that can colonize and infect the heart valve. So in those kind of individuals, there's certain high-risk procedures that are done where you would give prophylactic antibiotics prior to the procedure. So 24 hours prior the procedure, you would give these antibiotics, and then maybe a day afterwards. And those are listed here, any type of dental, not any type, but certain dental procedures. So if you're going to have a vigorous cleaning of your teeth where you're going to get into the gums and you're going to have a lot of disruption of the gums, or you have say a fairly bad mouth with a lot of decaying infected teeth that are going to be eliminated or pulled out, those are conditions where you need to have prophylactic antibiotics. And these are published in the American Journal of Cardiology and other journals, what the indications are for prophylaxis. And then there's other indications as well if you're going to have procedures where you're going to have your tonsils taken out, especially if there's a risk of infection or adenoids, those are areas, or any type of skin related, if you had a big abscess on your skin that would need to be IND'd, where there could be a transient bacteremia just from opening up that abscess. These are all indications where you might need prophylactic antibiotics. Most healthcare providers tend to over prophylax than under. So even procedures that may not need prophylactic antibiotics, it's frequently done, such as colonoscopy, cystoscopy, especially if you're just doing a routine scoping just for, prevention of colon cancer or something like that. You don't need that, but a lot of providers are a little bit more likely to use it than not. The thing with prophylaxis is, remember, you don't need 3 days before, 4 days after the procedure. If it's just prophylaxis, 24 hours before the procedure, just so you get 12 to 24 hours before the procedure, just so you get levels of antibiotics high enough to cover in case there is a transient bacteremia, and then 1 day after the procedure. I see so many times where prophylaxis is given a week before and a week after. That's unnecessary. So these are the indications. Next slide. And then looking at who are the people that should get prophylaxis. And again, looking at the PWIDs again, the prosthetic heart valve patients for sure. and then somebody with a significant heart valve dysfunction, like a rheumatic heart disease, or somebody with bicuspid aortic valve, or somebody that's had a history of endocarditis in the past, like a lot of the PWIDs would have. And then it gives you other conditions as well, certain congenital heart diseases and things like that. It's interesting because you may say, well, what about PWIDs just taking antibiotics before they inject drugs use? And that's a little bit, you got to have more control over that than just, and some PWIDs do that because they know about endocarditis, they know about that. So they'll have some oral antibiotics on board, they'll take a dose or two, or they'll mix it in with the drugs that they inject. But that's, again, a risky thing there because, you don't know the doses, and it's just not a thing to do. You have to have a more structured program for that. So it's very discouraged, much discouraged for IV drug users. Get them off the drugs. Don't try to promote it by giving them IV drug prophylaxis at the same time. Next slide. So I'm going to end here. Victor, is there any questions before I go through this case here?
Do we have any questions about any of the content that was just presented? Questions, comments before we move into a case? You can indicate it in the chat, or you can unmute yourself and ask your question.
I know for a lot of the individuals that are on this webinar, I know that a lot of you probably don't have contact with patients necessarily where you might see this, but I think it's important to understand because when you're doing any kind of discussions or consulting or anything, we're always consulting about Hep C prophylaxis and prevention, as well as HIV for that matter. But the IV drug users are also at risk for other things as well, and this is one of the major ones, is infections. And it can be a cellulitis, it can be an osteomyelitis, or an endocarditis, as we're talking about today.
I think we can move on.
So with that, I'm going to talk about this case here. It's an interesting one. It's a 25-year-old. He presents with a week-long history of progressive fatigue, weakness, achiness with muscle aches, bone aches, arthralgias, nothing real specific. He states he's had fever with chills over the past 5 days. I always like to say, is this documented fever, or is it just that you felt warm? Because documented obviously is a much better way of giving me an established fever rather than just saying, oh, I felt warm, because sometimes they don't have a fever. They just, I don't know, it's unrelated. But be it as it may, let's assume they were fevers. And it's been over a long period of time. It's not been just 24 hours, 48 hours. It's 5 days of a fever with unexplained weakness and that. And even just with that sentence alone, you might say, well, this could be some kind of a flu. It could be, most viruses don't drag on that long. They usually are a couple days and then they go away. And if it's another cause of a fever, say a bacterial infection, usually there's going to be a site for that infection. They're going to have painful sinuses. They're going to have a severe sore throat. They're going to have, pain urinating. They're going to have, a sore arm with redness from a cellulitis, those kind of things. So far, we don't have any evidence of that. So his past medical history, though, is positive. He's got Hep C, and it's untreated. Could that be doing it? Well, not really, because even active Hep C is not going to cause a fever with myalgias or arthralgias. So social history, he smokes, he drinks occasional alcohol, but here's the clincher. He's an active IV drug abuser and just used drugs 10 days ago. So he gives you that piece of history. So far, nothing real question. You think he's got some kind of an infection, hard to know what kind, hard to know where it's at, just based on the history alone, but he's a high risk kind of an individual with IV drug use for infections like we talked about, either, whatever. And also acute HIV, remember we talked about the acute HIV syndrome where, after using drugs, they get that viral load that goes sky high, but usually they get a real sore throat, they get diffuse adenopathy, but some of the history he has might go along with that as well. So we'll keep that in mind as well. So is there any other information you would like at this point? And I think, a lot of the history is, put pretty much in there. It's pretty good. Has he ever had this kind of symptoms before? Has he ever had infection before in his arm or anything? Does he have problems urinating? Does he have burning? Does he have pain where he was injecting drugs? Any of those things, headaches. I mean, things where you might localize where the infection or where this fever is coming from, is if it is an infection. So you ask a lot of those questions. You do a review of systems, going through the GI system, the genitourinary, respiratory. Is he coughing a lot? Is he short of breath more? Where it could be a pneumonia, like I said before, sinuses, something like that. So those are other information you'd probably want to get as well. So going to the physical, he's got a tachycardia. His heart rate's 100. Normal heart rate's about 70, 60. And a young man, it should be much, it should be a much slower heart rate than that, or a young man or young woman. Respiratory rate's a little rapid because normal respiratory rate should be about 14 or so. And he's got a fever, documented fever, 101 degrees Fahrenheit. So we know he's got a fever, at least on this exam. He's not in any kind of distress. He's not complaining of anything, shortness of breath, cough, or anything. He's got some non-significant nodes, less than a centimeter in his neck and axilla. Again, you're thinking, God, could this be acute retroviral syndrome? But so far, nothing specific. He's got a regular heartbeat, but he's got a murmur. And when you do a murmur evaluation, you stage it according to grade. The higher the number, the more significant the heart murmur is. I mean, when you get to a grade 4, you don't even need a stethoscope. You can hear it almost beating through the chest wall there. So he's got a fairly significant heart murmur. And you ask him, you say, does anybody ever told you you've had a heart murmur before? And he states, no one ever told him he had a heart murmur. So either they missed it, which is hard to believe with a stage or grade 2 to 3. So now we've got a person with a fever, aches and pains, myalgias, and a new heart murmur. Let's assume it's a new heart murmur. So now hopefully the puzzle is starting to be put together, and you're starting to see a picture forming where maybe we have a serious problem going on here, especially since he has a history of IV drug abuse. And I'd be looking real closely at his extremities to see if there's any sign of redness or tenderness over the over the injection site, because that would be definitely something where he could have had a cellulitis and then had the bacteria go into the blood vessel and then cause an infection that way as well. But everything looks clear. The lungs are clear. He doesn't have any pain in his abdomen. Extremities are normal. So right now, there's no source for this fever other than he's got a grade 2 to 3 heart murmur. And hopefully you're all putting this together. Next slide. So now we have several questions. Question number 1, what are the possible causes of his fevers? And I think everybody in the audience would agree right now. I mean, you could look at a lot of different options here, but he hasn't complained of anything else, ENT, lungs, urine, diarrhea, anything where there could be another source. Even his extremities are fine. So now you're down to, is this just a viremia? Is it just a non-specific virus, which is hard to believe since influenza, even COVID doesn't carry on that long with fevers and that. But, or is this acute retroviral syndrome? It's possible. I mean, he had some non-significant adenopathy, fevers, aches and pains. So it's possible, definitely. But the murmur puts an additional concern that this might be something more than just a virus. It could be a bacterial endocarditis. And so that's where you put the pieces. Because remember, fevers and changing heart murmur or murmurs are the 2 most common presenting causes of endocarditis. So what workup would you do on this patient now? Well, you get normal blood work. You get a CBC to see if his white count was elevated or he had any abnormalities. You get a CMP, which would check for his liver, kidney function, just give a variety of different things, and then definitely get blood cultures. Because that's going to be, if this is suspected endocarditis, one of the major criteria for diagnosis is positive blood cultures. So you're going to get blood cultures, and you're not going to get just one. You're going to have the lab tech come in and say, okay, draw one now, come back again in 10 minutes, 15 minutes, draw me another set, come back another 10, 15 minutes again, draw me a third set, because we want to prove that it's a persistent bacteremia, not just transient. So that's how you do that by getting several different blood cultures timed apart. Now, hopefully, question number 4, would anybody in the audience like to give him antibiotics and see him back in 1 to 2 weeks? So frequently in clinical settings, you see people and you say, oh, let me just give you you probably have some respiratory, give you a Z-Pak, I'll give you a Levaquin, I'll give you something, and we'll see if that takes it away. Something simple to do. Don't ever do that if the patient's not showing signs of sepsis or something serious. I mean, if the patient was hypotensive, if he was tachycardic, he'd go into the hospital. Or if he was having severe cough with purulent sputum, you probably have a diagnosis of a respiratory problem, but you don't have anything here. By giving him antibiotics or her antibiotics, you're going to screw up the blood cultures, because those antibiotics are going to transiently suppress the bacteria in the bloodstream. And so your blood cultures will be falsely negative. And that's one of the commonest reasons for a condition called culture negative endocarditis. I hate seeing those in the hospital, because then I don't know what I'm treating then. Could it be staph? Could it be strep? Could it be gram negative? Who knows? And then I have to put them on tons of antibiotics rather than specifically going after one organism. So unless you know that there's some infection and you know where it's at, what it is, don't just give antibiotics willy-nilly, because that's going to, especially when you're trying to prove a case of endocarditis. So hopefully the answer to number 4 would be a big NO. Final slide. So let's look at some of the labs that came back. So he's got a hemoglobin of 10 and a hematocrit of 30. That's an anemia. Normal hemoglobin for a young man or woman is anything above 12.6. So he's got he's got an anemia. And so, this is where it could be something acute, which endocarditis can cause anemias. It's something that we'd have to look at and see if it's from the endocarditis. Once you start treating it, the blood count will come back to normal. White count is elevated. You can see the normals there, 4,500 to 10,000. He's got a white count of 14,000. And that's pretty commonly seen in any kind of an infection. Now, in a viral infection, you don't see white counts going up like that. And so bacterial infections are usually where you'll see white counts going up like that. And if you got what's called a differential, more likely than not, you'll see a predominance of white cells, polys they call them, rather than lymphocytes. Lymphocytes will go up in a viral infection, polys go up in a bacterial infection. And then finally, the platelets. See that the platelets are higher than normal. They should be between 150 and 300, they're 400,000. The reason for that is a platelet, if you've ever heard of acute phase reactants like a cedrate or a CRP, those measure inflammation in the body. Platelets do the same thing, they measure inflammation. And we know that any infection will cause inflammation. So it's non-specific, but it just shows there's a lot of inflammation going on. His kidney function, he's got abnormal kidneys. For a young man or woman, a creatinine should be 0.3 or 0.5 to 1.2. And he's got 1 of 2. And if you drop down to the urine, you'll see that he's got red cells and red cell cast. What does red cell cast mean? That means there's inflammation in the kidney. Why would that occur? Very simply, remember immune complexes, emboli that are being shut off from the vegetation on the valve, lodge in the kidney and cause the kidney to react to it and cause inflammation. So that adds more fuel to the fire, so to speak, that he's got some kidney involvement with this bacterial endocarditis. And then his liver enzymes, SGPT, OT, they're elevated, both of them 85, 55. More likely than not, that's from his hepatitis C, which really, doesn't have anything to do with his endocarditis at this point. And then finally, his blood cultures. So you get a call from the lab saying, hey, it looks like there's some bacteria growing in here, and they're gram-positive cocci clusters. And I can tell you, for those of you that aren't microbiologists or never had a microbiology course, gram-positive cocci usually are staph or strep. Strep usually occur in chains when you look at them under a gram stain. Staph are in clusters, like they all cluster together in a little ball, so to speak. So gram-positive cultures or cocci clusters, more likely than not, is going to be a Staph aureus. So indeed, this patient had a staph aureus endocarditis. The patient was treated with antibiotics for 4 weeks. He stabilized. The only complication he had was the kidney issue, which cleared up, and his creatinine returned to normal. He's being followed closely because of that heart valve, and eventually he may need a heart valve replacement because it was damaged, but he didn't develop any heart failure, didn't develop any conduction abnormality. So this was an IV drug user that developed bacterial endocarditis. So I think that's my final slide, and we're pretty much right on time as usual. And I hope this was a good presentation for you. It's not the usual one I present with Hep C or HIV or anything, but it's one that was requested per Victoria. So I presented it the best way I could relating to IV drug users.
Thank you. I did have one question though, Dr. Gulick. So in like that instance, for like a patient that you had just described, and he had that patient had hepatitis C and endocarditis, would you want to treat that patient's endocarditis first and then their Hep C, or would you treat their Hep C first and then their endocarditis?
No, I'd want to get the acute problem under control first. So I'd want to get that endocarditis out of the way and treat him appropriately there. Although, when he's on those IV antibiotics for 4 to 6 weeks, he's going to be sitting around doing stuff. And I mean, we could work his Hep C up and, give him 2 weeks or 2 months of treatment for the Hep C at the same time. Or, I try to see how the patient is functioning and get him into an opioid program there to try to get him off his IV drugs. And that's what really was done. We treated his HIV for about 4 weeks. And then we got him into an opioid abuse center to get him on buprenorphine and naltrexone. And then we treated his Hep C afterwards, and we actually cured his Hep C. So that was a sequence, but we didn't do it at the same time. And I treated the endocarditis first.
Okay. I just didn't know the process of that. I'm not like a medical professional, so I didn't know the process of like which one you should treat first. Like as we've discussed before.
Yeah, it's a very good question. And the big thing is getting him off the IV drugs, because he'll just go back into the same pot again. If he keeps using IV drugs, he'll get another infection. It'll affect the valve again because the valve's already damaged now. He'll probably get, not probably, I hope he doesn't, but HIV is another worrisome thing. He could get reinfected with Hep C and all those kinds. So the big thing is getting him into a good program.
Right. Are there any other questions or comments for the presenter before we sign off? I will type up notes and everything from the case study, so those will also be included in the follow-up email. Just as a reminder, please type into the chat box one thing that you have learned that will influence your practice, or one key takeaway from our session today. And then also, just a few reminders, our next session will be January 20th from 12 to 1, and our topic is STD protocols. We will have Dr. Gulick be our speaker again. And then also we urge participants to volunteer cases or come armed with some questions for our presenter, or if you want to submit a case. Because as we've stated, cases are where the real learning takes place. We will be sending out the recording and resources from this session within 24 hours. As stated before, CME is available for all healthcare professions, and we will have those directions in the follow-up email.
One thing, Victoria, I just wanted to mention that we're coming to the end of the year, and so we're going to plan for more programs next year, but we'd like to really have your participation in giving us ideas. What would you like to hear? Because I know there's a lot of individuals in the audience that are Hep C, and we can definitely echo as predominantly made to do Hep C cases and stuff, and we can do Hep Cs. We can talk about a COVID update. We can do HIV prep, pre-exposure prophylaxis, because there's new things going on there. There's a lot of things we could do, and just need your input as to what you would like to have done most. And we could do more Hep Cs and cases now. And so just let Victoria know, that would be very helpful.
Yep. And you can indicate those on evaluations. You could indicate those just by sending me an email, follow-up email attached to the string that's on, that you will receive the directions for the recording. Thank you, everybody, for joining us. And as stated, we hope you enjoyed our session. Thank you for attending.
Okay, see you, everybody.